Now let's push on to hypertension. When you think about hypertension, there are only two sets of numbers you really need to know for the exam. 140/90 for hypertension and 180/120 for hypertensive urgency. These are going to be in the vignette, but you're going to be asked about risk factors, clinical signs, and potential outcomes from not treating hypertension. Now, the risk factors are really important. Some of them are very intuitive and others you need to memorize. Obesity, diabetes mellitus, alcohol, physical inactivity, salt intake, your genetics is always important, and African Americans or the elderly are particularly predisposed to the formation of hypertension. Now, 90% of hypertension is essential or primary. Your book says it's due to an increase in cardiac output or an increase in total peripheral resistance. Not a big surprise here, right? Because the equation of cardiac output times total peripheral resistance equals blood pressure. Now, we need to be on the lookout for the other 10%. So this is secondary hypertension. Secondary hypertension is when we can actually identify a reason. Now, the cause for secondary hypertension is usually chronic activation of the renin-angiotensin-aldosterone system. This is something that you would see in situations such as primary hyperaldosteronism, or something like decreased renal perfusion, in which there's decrease in flow of blood to the renal parenchyma. That leads to compensatory activation of the RAS system. Another extremely high yield disease associated with secondary hypertension is fibromuscular dysplasia. Why is it so high yield? Because this is a rare situation in which you'll see a healthy young woman have hypertension. So let's remind ourselves about the structure of the arterial wall before we discuss this disease. Now remember, there are three tunica layers. We have the intima, the media, and the externa. We also have the internal elastic lamina or membrane and the external elastic lamina or membrane. The internal separates the intima from the media, and the external separates the externa from the media. Now, the internal elastic lamina is the outermost part of the intima. It helps counteract wall tension. So that's its job, so decrease tension. Now, what happens in patients with fibromuscular dysplasia? Why exactly this disease occurs is still being worked out, but some publications have come to the conclusion that these patients have excessively fibrotic medias. And this creates areas of lumen constriction. These excessive proliferation of scar tissue can make the media bulge, and it bulges into the lumen, and this decreases the radius of the vessel. And this bulging also occurs the other way. They can bulge out in this direction as well. As you can see, we've formed a small little aneurysmal-like dilation. We can see that better here in this renal arteriogram. The red arrows here and here are highlighting these aneurysmal small dilatations along the renal artery. So this is the kidney here. Now, how does this disease lead to hypertension? Well, again, we said we're taking the lumen of a vessel from normal to decreased because of these aneurysmal-like dilatations. This leads to decreased flow, and the kidneys get angry when they don't get enough blood. What do the kidneys do? They activate the renin-angiotensin-aldosterone system. All right, great. Up next is the discussion of hypertensive urgency and emergency. So urgency is different from emergency. A hypertensive urgency is blood pressure of at least 180/120 without end organ damage. The only difference is that a hypertensive emergency has end organ damage. Same pressures. Now, these super high pressures lead to end organ damage by damaging the vasculature in the organs that we're worried about. So this super high pressure in the brain can lead to encephalopathy or stroke. In the eyes, they can lead to retinal hemorrhages or exudates or papilledema. A favorite one for board examiners is to include a picture of papilledema. So papilledema literally means a nipple-like swelling. As you can see in this image, the optic disc kind of looks like a swollen nipple. Not that I've seen many of those, but this is important in understanding how hypertensive patients can present with swelling of the optic disc. The optic disc is where all the axons that are leaving the eye converge to leave the orbit and go back to the brain. So again, these axons coming together form the optic nerve. Now, why do patients with severe hypertension develop edema and bulging of the optic disc? So let's think about this. Let's draw our orbit connected to the optic nerve. So here's our eyeball, and the optic nerve is going back into the brain. Here we draw in, this is the skull, and then this is the eyeball sitting in the socket. So here's the rim of our cranium, and remember, the eyes grow as projections from the forebrain. So the optic nerve is covered with meninges. So normally what happens is CSF flows in this subarachnoid space that's covering the optic nerve without any problem. But if there's elevated pressures in the brain, so an increase in intracranial pressure in the skull, this is going to obliterate this drainage of CSF from the eyeball backwards. Now this impaired drainage of CSF from the eyeball back into the brain is going to lead to the changes that we see in papilledema. The accumulated pressure at the optic disc leads to transudation of fluid. This transudation of fluid will make the optic disc look very swollen and edematous. Now, why is this also dangerous? Well, guess what runs in the middle of the optic nerve? The central retinal artery and vein. So they are subject to compression from this increase in CSF that's unable to return back to the brain. Now this increase in pressure from the inability of CSF to return to the skull is going to increase pressures in the arteries and the veins in the retina. You can see here there's a microhemorrhage, and you can see that this vein here is bulging because the pressure for blood to return back into the skull is obliterated. So now these increase in pressures compressing the structures that are trying to return to the brain is not only going to lead to optic disc swelling, but it's also going to compress the veins and the arteries. Now what happens if venous blood cannot return back to the skull? Look at this vein bulging. So you can get bulging of the veins trying to return blood back to the brain, and you can also get tiny hemorrhages of the arteries because of the very high pressures. Now what about chronic hypertension? We talked about acute, emergency, and urgency. What are the problems of chronic hypertension? You need to worry about arterial sclerosis of the coronary arteries, the circle of Willis, the arteries that supply the brain, the arteries that supply the kidneys, particularly the renal arterioles. We can damage retinal vessels and the vasa vasorum of vessels. Remember, the vasa vasorum are the tiny arteries in the adventitia layers of vessels that supply the outer elastic lamina and adventitial layer and half of the medial layer. The involvement of elevated pressures in all of these different organs leads to the manifestations of chronic hypertension. So people with chronic hypertension get coronary artery disease, they get strokes, they get chronic kidney disease, they have vision problems, they are predisposed for vascular problems such as aortic dissection or aneurysm formation because we're not perfusing the layers of the vessel that are provided by these vasa vasorum. Now it's important to remember that increased pressures also have an effect on the heart. An unnecessary amount of chronically elevated blood pressures can lead to left ventricular hypertrophy.